Patients receive blood transfusions every day in hospitals and clinics. Most are uneventful. Unfortunately, some are not and may result in a transfusion reaction. Some reactions are immediate. Others may occur days, even weeks after the transfusion. During a transfusion reaction, a patient may display symptoms such as fever, chills, a rash or wheezing, high blood pressure, or increased heart rate. In most cases, the reaction can be treated and is usually harmless. However, some are deadly. In the next few minutes, we'll look at the most common transfusion reactions, how to recognize them, respond to them, report them, and prevent them.
Why is the patient bleeding like this?
Do we have the right unit of blood?
Some transfusion reactions are set in motion long before the patient is transfused. How? Because one or another of the safeguards for identifying either the patient or the blood sample was ignored. Acute hemolytic transfusion reactions are almost always the result of human error. The wrong blood was given to the wrong patient. It's frightening, and it can be deadly.
To avoid these types of mistakes, our institution and the American Association of Blood Banks have implemented some policies and guidelines that must be followed.
Those policies and guidelines begin here with the patient's chart. Before talking with the patient and taking a blood sample, check to see that a transfusion request has been entered into the chart and signed by the physician.
Good morning, Miss Evans.
Next, give the patient your name and tell why you're there. Ask the patient's name, even if you've talked to her every morning for the past 3 days. Turn it into a game, whatever it takes to get the patient to say her name. Once she does, check to see that the information on her wristband is the same. If the patient is unconscious, look at the name on the wristband. Then find another person who can identify the patient. Do not pre-label the sample tube. Draw the sample and then label it at the patient's bedside. The label must include the patient's first and last names, an ID number that identifies the patient and correlates to an identifying number on the request form, the date the sample was drawn, and the initials of the person who drew the sample. Check once more to see that everything matches. If it does, sign your name on the request form to show that you collected the sample. Do not ask clerical staff or someone else to sign for you. Then transport the sample along with the request form to the blood bank.
Hi, I got a stat order.
Once the sample reaches the blood bank, the patient's name and ID number are cross-checked with the name and ID number on the request form. If these do not match, or the form hasn't been signed by the person who drew the blood, a second blood sample must be drawn. If the names and numbers match, the blood bank will run a series of tests on the sample. Select and label a compatible component for transfusion and attach a blood transfusion record tag to the unit. The unit is now ready for pickup. Before the blood component is released, hospital staff must complete and deliver to the blood bank a dispensing request form. It verifies that the order for the blood component is part of the patient's record. The dispensing form must be signed by an RN or MD in most institutions. Both the dispensing form and the original transfusion request form will be filed in the blood bank. The last person who can prevent a transfusion reaction caused by incompatible blood groups is the person who starts the transfusion.
It actually starts with the person that draws the blood. They're our first hope and they're our last hope. The person that does the transfusion of it are our last hope because they're the ones that has to check everything to make sure it's accurate. The first hope is the person that draws the blood to make sure that everything is right and drawn correctly. And actually our staff does a very good job with the drawing of the sample. In fact, we find that the staff does very well until they walk back into that patient's room. They fail to identify that patient that one last time.
Do not remove the blood transfusion record tag from the unit. On it is printed the patient's name and blood group, the donor's blood group, the date the blood component was prepared, the date it expires, and a unit number. The same information is on the unit bag it's attached to. You'll need this information as you make your final ID check. Look at the blood transfusion record tag. Then check to see that it contains the same information that's on the blood bag itself. Finally, check the patient's wristband. If all three match, sign the blood transfusion record tag and start the transfusion. If there is any discrepancy, return the unit to the blood bank. If, despite your efforts, there is an immediate hemolytic reaction, the patient may become feverish, develop chills or rigors, experience abdominal or back pain or pain at the infusion site, or the patient may simply say, "Something's not right." If the patient has had a general anesthetic, the blood pressure may drop, or the patient may begin to bleed from multiple sites. If a urine catheter is in place, the urine may become dark red, almost the color of Coke. If any of these signs appear, stop the transfusion. Keep the IV line open with saline. Notify the physician in charge. Then notify the blood bank or transfusion service. Monitor the patient and follow the directions specified by your institution. Finally, return the blood bag, any solutions that were infused through the same IV line, required blood specimens, and the completed blood transfusion record tag to the blood bank. An allergic reaction is usually less severe than a hemolytic reaction, but it is more common.
We frequently see these reactions in patients that have been multiply transfused in the past. For example, children with sickle cell anemia, cancer patients, and any other individuals who have received transfusions. The symptoms are usually mild, and they respond quickly to the administration of antihistamines.
The symptoms may include a rash or redness, often around the infusion site, itching, raised hives, wheezing, or respiratory difficulty. If any of these symptoms appear, stop the transfusion. Call the physician and give the patient the prescribed medication. Once you've done this and the symptoms have subsided, you may restart the transfusion. Even with a mild allergic transfusion reaction, the blood bank must be notified. The most commonly encountered reaction is the febrile non-hemolytic transfusion reaction. These occur in about 1% of all transfusions and appear while the blood is infusing or within 2 hours of completion. Symptoms may include a rise in temperature of 1 degree Celsius or more, and chills or rigors. Occasionally, there may also be hypotension or increased heart rate. The symptoms are often so mild and nonspecific that febrile non-hemolytic transfusion reaction is generally diagnosed by the exclusion of other problems.
Other etiologies for the increased temperature must always be considered. For example, the fever may be due to bacterial infections, medication, or post-surgical. Although you have to consider many other possibilities, whenever you suspect a transfusion reaction, stop the transfusion, keep the IV line open with saline, notify the patient's physician, and notify the blood bank.
Another transfusion reaction is acute circulatory overload. This may occur when the units being transfused are infused too fast. The patient's cardiovascular system simply can't handle the volume. It may especially occur in a patient with compromised cardiac function. Even a small additional volume of fluid may be enough to push the patient into cardiac failure and pulmonary edema. Symptoms may include difficulty breathing, coughing, systolic hypertension, headache, chest discomfort. If these symptoms appear, immediately stop the transfusion. Maintain the IV line and place the patient in a sitting position. Alert the doctor and follow instructions. If the transfusion is critical for patient therapy, use the lowest possible infusion rate. Circulatory overload can lead to congestive heart failure and pulmonary edema. Finally, be sure to notify the blood bank. Although infrequent, reactions due to bacterial contamination do occur. In most cases, these septic reactions appear rapidly during transfusion. Bacterial contamination of transfused blood should be considered when the patient develops high fever and severe chills or rigors, especially when these are accompanied by cardiovascular collapse.
If bacterial contamination is suspected, stop the transfusion immediately and obtain samples as soon as possible for gram stains, blood cultures from both the blood component unit and the patient. Don't wait for the result of this laboratory test. Start treatment immediately with intravenous antibiotics combined with therapy for shock, renal failure, or disseminated intravascular coagulation if present.
Not all transfusion reactions occur immediately, but the majority appear in the first 15 minutes of the infusion. For that reason, it's your job to stay with the patient for 15 minutes once you've started a transfusion. It is a critical time for the patient, whose very health and well-being are in your hands.